Okay, so any questions on the first half about hepatitis or STIs, STDs, anything like that? All right, so we're going to finish up with kind of a random smattering of endocrine stuff. As I mentioned, we'll do diabetes. The next time is kind of a huge topic, probably like 90 slides just on diabetes. Type 1, type 2 are pretty quick, but 3, 4, 5, those are much more harder to cover, right? Just kidding, just kidding. Anyway. So, like I mentioned, it's kind of a random smattering of stuff. So, hyperprolactinemia is one issue. Why are we concerned about hyperprolactinemia?
Or it could be a tumor.
Yeah, so it could be caused by tumors. What does it cause in our patients? Right. So, normally you think prolactin causes like milk production, right? How, might that be bad in male patients? Yeah, gynecomastia, you can certainly see with that. What does it do to your ability to get pregnant? Yeah, it inhibits ovulation. Yeah, so especially imagine like someone who has like PCOS, polycystic ovarian syndrome, they tend to have kind of higher prolactin levels. They have a hard time ovulating and getting pregnant, right? So that's a huge thing for some patients. So usually you end up seeing it's caused by like prolactin secreting tumors, and so basically you can see this galactorrhea that can happen there. So again, kind of abnormal milk production, amenorrhea or impotence, infertility. And so what you're going to find is that when we talked about the behavioral stuff, you remember when we block dopamine with our antipsychotic, what did that do to prolactin? Increase it or decrease it? Actually, it was like a seesaw kind of effect. So I blocked dopamine, you see more prolactin, very similar to what we saw with acetylcholine. Remember, we saw if you block dopamine, you have more acetylcholine activity. Same thing happens here. So as you might think, if we have high prolactin levels, how can we inhibit that? Give dopamine. Yeah, give something to act like dopamine. So we have a couple of drugs that will do that. So usually these are considered ergot alkaloids. Remember we talked about migraines? How we had like DHE was kind of an ergot alkaloid. Sort of similar to that. So you have things like bromocriptine or parlodel that can be used. Again, any dopamine active agents typically are going to cause a lot of nausea and vomiting associated with them. You can end up seeing potential issues with blood pressure, see things like orthostatic hypotension happening with this. So just watch out for that. But like bromocriptine used quite frequently to try to stimulate ovulation for patients with hyperprolactinemia. So you might see that used for like PCOS patients and other ones who have high prolactin levels. Another one called cabergoline, probably a little bit more likely to see side effects, mainly due to the high affinity of the drug, but it could be used as a backup if bromocriptine was not going to be a good option for them. Okay, next we have our androgens. We had a short section for the guys. Unfortunately, we have a whole section just talking about female hormones, but sorry guys, we get short shrift on this. So androgens. So again, all of our steroids kind of share very similar precursor molecules. So normally from cholesterol, we're going to have lots of different types of steroids being made. So we'll talk about OB-GYN stuff in the next section, last part of the class. We talk about estrogens and progestins, but a lot of them end up getting formed from these kind of precursors, right? So we have progesterone, which can be really important for normal menstrual cycles in female patients. You're going to see this actually gets converted over to testosterone, but then what do you notice testosterone getting turned into? Estrogen, right? Does anyone know the enzyme that does this? DHT is something that testosterone gets turned into. We'll talk about that in a few minutes. There's an enzyme called aromatase. So remember we talked about aromatase inhibitors, right? Remember we saw that can actually lead to higher testosterone levels in females and see kind of masculinization occurring for them, right? So again, aromatase is an important enzyme here, but also things like aldosterone, right? What does aldosterone do for us? Not heart rate necessarily. It's like an indirect effect. Maintains like blood pressure and blood volume, right? It helps us to regulate water, either secretion or retention. Affects potassium levels, things like that. Remember, so aldosterone. Go back to your renin-angiotensin aldosterone system and kind of review some of that stuff. But yeah, so again, all these molecules kind of share these this same basic structure. And with some of these hormones we can give, these steroids, we can actually see some cross-reactivity there, right? So again, if you remember things like spironolactone. Remember, spironolactone was based on aldosterone antagonist. We also remember that it actually had some modifying effects on androgen receptors, right? So when I say androgen receptors, I'm referring to testosterone receptors, and that caused what in male patients? See, gynecomastia, right? Because you're actually causing a less testosterone effect to be occurring, so that kind of tips the balance more towards estradiol and things like that, right? So again, with hormones, anytime you're monkeying with this stuff, you have to think about what other receptors are being affected. You have to think about what kind of the patient's baseline activity is. So for instance, with spironolactone, for guys it was causing more of a testosterone deficiency, leading to things like gynecomastia. However, for female patients who typically have less testosterone activity, because that was a partial agonist, it actually increased testosterone activity over baseline. So you saw things like hirsutism, you saw things, some more of those kind of masculinizing type of effects. So just know there's some bleed over. This is going to become more important when we're talking about oral contraceptives, and when we're talking about things that will have some anti-androgen activity, or they'll have pro-androgen activity, because that'll affect the side effects your female patients will be experiencing when they're taking these drugs, right? More specifically, talking about testosterone, what does testosterone do for us? Right, so it's an anabolic steroid, right? So again, it causes growth to occur, right? So it's very important. Where does it get made? In the testes, right? So it's going to be primarily produced in the testes. We're going to look at the feedback loop with that. Now, what you normally see is testosterone does have good androgen activity, but the more kind of potent version of it, kind of the beefed up version, so to speak, is going to be this dihydrotestosterone. So you ever see DHT? That's what we're referring to, and so that's going to be 5-alpha reductase as the enzyme that's going to be affecting that. And remember where we talked about this before? Had to do with prostate, yeah, so BPH. Remember we talked about how DHT is very potent in causing growth of that the epidermal tissue of the prostate, right? And that was impinging on the urethra, and we saw BPH develop because of that. And again, remember how we treated that? Decreasing DHT levels, right? That's one way we could do it. So actually, by giving a 5-alpha reductase inhibitor, you saw less DHT activity. So just know DHT, more active than testosterone typically. Now, some of it is going to be converted to, oh, yes, ma'am. Yeah.
But if estrogen is produced from testosterone from proteins, then if testosterone goes down, how is estrogen going up?
Insofar as what sort of situation?
Specific. You were just saying that if there's a decrease in testosterone, you'll have an increase in estrogen.
Oh,
but if estrogen is coming from testosterone, then how is it going?
So that's one. Yeah, it's one way it can be produced. There's probably some other, because again, there's other varieties and other mechanisms. That's just kind of one of the basic kind of pathways there. But when you think about, like when I was referring to spironolactone specifically as being a partial androgen receptor agonist, so like for female patients who typically have lower testosterone activity, when you have a partial agonist affecting those receptors, now all of a sudden you're kind of increasing that level of activity versus a guy who's going to have mainly testosterone around, it's going to end up decreasing activity, right? Because it's a partial agonist rather than. Exactly, it's all going to be on a kind of relative scale of things, because you can have some female patients who produce a lot of testosterone, you can have guys who don't produce a whole lot, right? So again, it's going to be kind of a balance there, and depending on how we're kind of monkeying with things by giving exogenous hormones, huh?
That makes sense.
Yeah. So anywho, so again, some of it's going to be converted to estradiol by aromatase, that's our primary estrogen that the body produces. And again, the other thing you're going to see that gets metabolized in the liver. Now it's important because we talk about the OB-GYN stuff. We're going to see that the estrogens can have a lot of effects on the liver because they get metabolized there. You're going to see testosterone can also have some pretty negative effects on the liver as well. So when you think about the way we give androgenic hormones, right? You typically do not want to give them orally because they tend to be very hard on the liver because they undergo a lot of first pass. A lot of these products are going to be either given transdermally or they'll be given, say, intramuscularly, things like that. So we're going to see a lot of parenteral products for testosterone rather than utilizing oral products, and for the most part. So just kind of keep that in the back of your mind. But just like any hormone, it's going to be going to the nucleus. It's going to be affecting transcription of different proteins and things like that, and expression of genes. And so that's why we get the kind of the masculinizing sort of effects here, right? So you get kind of the growth. Does testosterone have a positive or negative effect on the bone? What do you think? Positive effect on the bone, positive effect on muscle growth, positive effect on, during puberty, you get this masculinizing effects, for your male patients. So lots of effects that are happening here. Now, if you were to look at between, say, like a male and a female patient, you're going to find that basically this whole upper 2/3 of this is going to look identical, right? So you have the hypothalamus releasing gonadotropin releasing hormone. That's going to stimulate the pituitary gland, the anterior pituitary, to release LH and FSH. Anyone know what LH stands for? Luteinizing hormone, and then FSH. Yeah, follicle stimulating hormone. Both of those will have positive effects on producing testosterone within the testes, right? That's where we get sperm production and whatnot. If you have enough testosterone, that will end up causing a negative feedback loop to occur where you're going to shut down production of GnRH, you'll shut down production of LH and FSH. So what do you think might happen if I were to give exogenous testosterone? So you stop producing your own testosterone, right? Because again, your body senses it has enough testosterone around, and you're not getting that LH, FSH sort of stimulation there. So what do you think happens to the testes? They atrophy, right? So again, you see testicular atrophy occur as a side effect of giving these exogenous androgens, right? What do you think it does to sperm production? Typically decrease, right? So you can see infertility related back to this, right? So yeah, these are things you want to think about as side effects for patients who are having to have exogenous hormones being given. And again, who do you think might abuse androgens?
Athletes.
Yeah, I think athletes, bodybuilders, things like that. And these are some of the side effects they run into with some frequency there. Okay, so looking at kind of the natural hormones we have here, so we have our naturally occurring testosterone. You see lots of different products that are here. Some of these are going to be transdermal products, so you can actually absorb through the skin. Some of these are going to be ones you're actually going to be injecting. There's way too many brand names here for you guys to memorize. Just know that those are the typical ways that we can give testosterone. Orally, it's not really going to have a good bioavailability, not done very routinely. And then that hydrotestosterone gets converted to DHT, or T gets converted to DHT by 5-alpha reductase. That's an important enzyme. There's ways we can inhibit that, as we know, because we looked at that back in BPH, but we'll talk about those again briefly here. There's some synthetic forms we can give. Usually they're like kind of modified versions of testosterone, so things like methyl testosterone. You just add a methyl group onto it and increase bioavailability. So we have PO versions of this. We have this fluoxymestrone. We have oxandrolone. These are all oral available agents. And so we mentioned, who might be good candidates for receiving androgen therapy? Who might you use this for? So the obvious one is what? Guys with low testosterone, right? So they have low testosterone, they have low libido, and they have no energy, things like that. They have low testosterone. That could be one. Who else might benefit from this, though? I don't know. Do they do that normally? I have not seen that typically, no. So think about people who want to put on some mass, right? So think about people like chronic wasting conditions, right? So think about like end-stage AIDS patients. Think about potentially cancer patients who are having a hard time, kind of putting weight back on after they've been kind of malnourished for a period of time. So those are cases where we may actually want to have some extra testosterone activity to try to utilize the anabolic effects, right? They're not hoping, trying to improve their bench to 350 by any means, but you're at least trying to get them to put a little bit of mass back on, a little bit of muscle mass, right? So typically what you're going to find as far as the physiologic actions of these androgens, you're going to find testosterone receptors in places like the internal genitalia, skeletal muscle, erythropoiesis, right? So this can actually stimulate red blood cell production, which could be very useful for athletes as well. And then the DHT is going to be better for things like the hair follicles. This is where we see a lot of male pattern baldness and things like that can develop here. External genitalia tend to develop more with exposure to DHT. And then we can also find that with the estrogen receptor-mediated effects, mainly due to conversion of testosterone into estrogen or estradiol bioaromatase, so we can see effects on like the bone and also on the libido as well. If you think about, you don't want to get estrogen activity too early on the bone, because what can that do to the growth plates? Close them up, right? So if you were to get this prematurely, it could actually cause, kind of a shortening of the stature of the patient overall. They may not be able to get kind of their full height developed in that case. So therapeutic uses we mentioned for male infertility. Sometimes testosterone can help to stimulate production if they're not really kind of developing enough testosterone on their own. Potentially they've had something like their testicles removed due to cancer or injury or things like that. You can actually help to restore gonadal function by giving testosterone. Osteoporosis is good for having testosterone around to stimulate bone production and kind of inhibit osteoclasts. And again, this is referring to testosterone, like a methyl testosterone. Either of these would be fine when you're administering these. And then in some cases, rare cases, you may try to do hormone replacement therapy combined with estrogens. I don't really know a whole lot of use cases for that commonly, but again, if you talk to an endocrinologist, they might be able to give you a better idea. In some cases, we'll do for inoperable breast cancer, they might actually give fluoxymestrone. Tends to that one probably does not get converted over to estrogen quite as easily as you see with testosterone, so it may have some better effects on kind of increasing, kind of the testosterone activity versus not increasing estrogen. Possibly. And then as I mentioned here is one of the things I would probably see a little bit more commonly is to try to offset weight loss due to things like, injury, AIDS, other chronic diseases where you see a lot of muscle wasting, a lot of mass loss in there. And then for anti-androgens, we might use it for things like, BPH, metastatic prostate cancer. In some cases, we may actually give this to treat hirsutism in women, right? So they're having too much androgen activity. You can actually inhibit that by giving some anti-androgens, which we'll look at here in a few seconds. So typical formulations we mentioned, there's oral varieties. Typically, testosterone gets metabolized pretty fully in the liver, so due to that first pass effect, testosterone itself is not given orally. However, we can utilize these kind of modified versions, so like methyl testosterone and things like that. Now, again, these are very hard on the liver. You're going to find that hepatitis is very common with this. You have to monitor liver function tests and whatnot. So again, usually the oral route is not our preferred route. We can do this via injection, so testosterone can come in kind of oil bases. And when you inject things into the muscle in an oil base, what do you think that does to the duration of action of the drug? That's a lot longer, right? So you think like Depo-Provera and other kind of depot sort of drugs, you think about them lasting a lot longer. So depo-testosterone is like a variety of that, where it may last, say, a few months, and I go back every 3 months to have a new injection, things like that. And then obviously there's transdermal formulations, there's gels, there's creams, there's patches, all kinds of different ways to administer this in a transdermal sense, because it is lipophilic enough to cross the skin and have its effects there. Okay, now looking at anti-androgens, we have some androgen receptor antagonists. We have things like flutamide and bicalutamide. What do you think this might do for a male patient? What type of effects might you see, side effects? Yes, you'd see, well, not menopause, because that's more of an estrogen deficiency, but you'd see more kind of estrogen effects starting to pop up, right? So you can see more things like gynecomastia and changes like that. We mentioned spironolactone being kind of a mixed androgen receptor and mineralocorticoid receptor antagonist. We'll talk more about mineralocorticoids a little bit later. But again, with it being a partial androgen receptor agonist, it can decrease testosterone activity for guys, but increase testosterone activity for ladies, depending on kind of what their situation is. Here we have one that's a mixed progestin receptor agonist and androgen receptor antagonist. It's called cyperterone. Again, not used too commonly, but the one thing you will see used very commonly is going to be for BPH patients, this 5-alpha reductase inhibitor. So we have things like finasteride. Anyone remember the other one we used? One called dutasteride. That was the other one that's going to be important there. So as I mentioned, side effects here. So again, if you're giving androgens, is where you can see prostatic enlargement, right? So and ultimately you can have a risk for prostate cancer by kind of stimulating that tissue to grow, kind of unchecked there. I mentioned the testicular atrophy. I mentioned gynecomastia. You actually see increase in acne as well. For some of these patients, you're kind of causing increased sebum production and blocking off those follicles. You see bacteria start to grow there. And then erythrocytosis is a potential effect here. Again, some people may abuse it for that purpose, but you may not see it in all male patients there. The other thing you're going to see is you're going to have some bleed over and have some mineralocorticoid effects, so it'll kind of act a little bit like aldosterone, and so you can actually see some sodium and water retention. So this could be problematic in patients with CHF who already have issues kind of dealing with their volume anyway, right? Then I mentioned the hepatic effects, possibly hepatitis, especially with giving orally administered drugs. It can still happen with like transdermal or say like intramuscular testosterone, but more often with the oral varieties you're going to see that the hepatic effects. And then we mentioned the masculinization of women. Again, not typically given to most women. However, maybe cases like you mentioned with the inoperable breast cancer, or if they're using it for muscle mass or things like that, you may see it used occasionally. Okay, so we mentioned for BPH we can use DHT inhibitors, so kind of a review there, but by blocking 5-alpha reductase you prevent production of DHT, which is again more potent than testosterone, so that's where finasteride and dutasteride come into play here. And then we also have some GnRH analogs, so these are actually going to be drugs that kind of simulate the functions of GnRH, and so what do you think this would do on the anterior pituitary? So it depends on the dose, but say at normal physiologic doses, if I was replacing GnRH, like let's say for instance I had the hypothalamus, I had some injury there, there's a tumor or something, I can actually replace GnRH by giving this, and I can stimulate LH and FSH. Remember that had a positive effect on it's gonadotropin releasing hormone, so it stimulates release of LH and FSH. You can also give higher doses of that, and this can actually help to shut down production. Basically by giving enough GnRH, it will kind of shut down the whole system essentially, and so this may be used occasionally if you need to, if you have like testicular cancer or prostate cancer, you need to shut down testosterone production. That's a good way to do it is with this GnRH. But more often than not, also used as a replacement, especially in pediatric patients who maybe have any kind of growth hormone deficiency and things like that. They may utilize these GnRH hormones. But goserelin and leuprolide are the two most common ones you're going to see with that. So again, just kind of looking at the whole axis here, so again we have the hypothalamus into the anterior pituitary. You see the GnRH antagonists obviously can affect that, but GnRH agonists like that leuprolide and goserelin I just mentioned, they can either have a positive effect here or it could be a negative effect. So again, it all depends on the dose. The bigger the dose you give, the more negative an effect it's going to have to kind of inhibit the whole system there, right? So again, spironolactone is going to have kind of a negative androgen effect, and then here's where our 5-alpha reductase inhibitors come into play, like finasteride and dutasteride. So, and then drugs that directly block the androgen receptors. So you can see there's several places where we can kind of inhibit the system a little bit, and just remember that anytime you give testosterone, you're going to cause that negative feedback loop to kick in. It will shut down GnRH and LH FSH production, right? Okay, up next we have adrenocortical insufficiency. So who do you think might develop adrenocortical insufficiency? Good, yeah, so if we're giving them exogenous steroids, we may have issues with that for sure. How about people might have it without the influence of drugs? Yeah, so potentially if they had a tumor, like tumor resection or anything like that, that's where I would see this more commonly. So basically, when we're looking at corticosteroids, and we've talked about glucocorticoids probably since day one, it would seem like, right? Because we use them in so many different disease states. So we know the glucocorticoids, and what do they typically do to the immune system? They suppress it, right? There's also the mineralocorticoids, which we've kind of alluded to before, and this is the main one you're going to see is aldosterone. And remember, think mineral, think salt retention, think water retention, right? Because where salt goes, water likes to follow. So this is really important for maintaining water balance, blood pressure, and mainly is going to help to increase sodium reabsorption from the distal convoluted tubule. Remember what it excretes in place of sodium? You lose potassium. Remember, in the distal convoluted tubulus, we're going to see sodium get exchanged for potassium. And so if I were to give, say, like spironolactone, which is an aldosterone antagonist, what do my potassium levels do? Because I'm excreting more sodium, more water, potassium goes up, right? So again, think aldosterone, think the potassium and sodium kind of being on the two sides of the seesaw there. Anyway, so typically what your body produces from the adrenal glands is cortisol, right? And so again, another name for that is just hydrocortisone, the same stuff you get, for topical rash or itch or anything like that. And normally we secrete 10 to 20 milligrams a day daily, but that's not going to be a continuous amount throughout the entire day, right? So we have circadian rhythms, which will cause it to be released in higher amounts in certain parts of the day, lesser amounts in other parts. And then also, what do you normally see with stress? Like what happens to cortisol levels when you're stressed out? Right. I would always love to do a study where I looked at cortisol levels from like day one of your guys' schooling all the way to like the midpoint of the didactic year, and then right before you go on rotations. I guarantee you'd probably see a nice kind of bell-shaped curve with that happening there. But anyway, so stress should increase cortisol, right? So that's what we would normally see. So you imagine if you had someone who's not able to produce, they had adrenal insufficiency, say like they lost function of their adrenal glands for whatever reason, and they get stressed out. Guess what? They may not be able to produce enough cortisol or any cortisol, and then they can have major issues from that, right? So we need to be able to replace that. So that's what we're going to be focusing on here. So imagine like chronic insufficiency here, called Addison's disease. See a lot of weakness, fatigue, weight loss, hypotension, because again, we're not maintaining our water volume appropriately. And they also have a lot of glucose intolerance that can come about, or maintenance of their normal glucose levels. And so, of course, what we run into, especially with patients who have really bad adrenal insufficiency, when they get really stressed out, they can develop circulatory shock, go into death. So this is not something we like to see there. So typically what they'll do is they'll take a normal amount of hydrocortisone a day, so try to replace what their adrenal glands would normally produce, say like 20, 30 milligrams a day. And then if they were to say get an illness, say they get the flu, or say they have some other like major physiologic stress, then we would actually increase their amount. So you'd actually give them a prescription where you'd say take 20 milligrams a day, take an extra 5, 10 milligrams as needed when stressed out. You educate them on when those cases would be when you actually want to take that. Because otherwise they come in, their blood pressure's all over the place, usually pretty hypotensive. You give them a ton of fluids and they still have a hard time really kind of getting their pressures up. You give them hydrocortisone, all of a sudden that kind of fixes all their issues there. So we see this, we have one frequent flyer that comes into the ER all the time for these adrenal crises because they just have a really hard time keeping her level straight. But you may also give with another drug called fludrocortisone. Florinef is another name for that. And basically this is going to have just pure mineralocorticoid effects. So cortisol normally has some glucocorticoid effects, normally has some mineralocorticoid effects. This has pure mineralocorticoid effects. So mainly just used to help keep blood volume up, to help maintain that blood pressure appropriately. Right? Okay, the last thing we'll talk about here is going to be thyroid pharmacology. So obviously we want to keep our thyroids in check. What could happen if we have hypothyroidism? Weight gain, normally see, huh? Yeah, hair, nail changes. What are the energy levels usually doing? Pretty low, right? So we're going to see that. We're going to see, obviously, the flip side of that is going to be hyperthyroidism. We're going to see the opposite effects, usually sweaty, tachycardic. So what do you call that when they have like really bad hyperthyroidism? Yeah, so I'm thinking like more like emergency settings, like thyroid storm. You see thyroid toxicosis, another name for that. So we're going to look at drugs that can either replace thyroid hormone, or we're going to look at some drugs that can actually inhibit production of thyroid hormones. So we got to get into the basis from the physiology standpoint. Have you guys covered this at all yet? All right, good. So I'm not going to have to belabor the point. We'll go over the basics here. Obviously, you can have issues at the level of the thyroid gland, but it can certainly happen above that. So similar to what we saw with, say, like testosterone production, you have the hypothalamus, you have the pituitary gland, you have the target organ here. So again, what does your, say, pituitary gland release to stimulate thyroid hormone production? TSH, right? So if you had someone who, say, was hypothyroid, and what would you imagine their TSH levels to be? High, yeah. So that could be an issue where they're producing a lot of TSH to stimulate the thyroid, but they don't have the means to actually produce the hormone itself, right? So you'd expect to see, and what do we measure the actual hormones for thyroid gland? Yeah, T4 and T3, right? So which one's more active? T3 is the more active form. T4 has to get converted into T3. Usually you'll find more circulating T4, but T3 is the kind of the predominantly active hormone. That's important to remember. So again, you imagine someone has low T3 levels, they would have high TSH levels. There could be an issue with specifically the thyroid gland. But you can have issues above that as well. So for instance, if you had a problem with the pituitary gland, you'd see that you have thyrotropin releasing hormones, or TRH, that coming from the hypothalamus. If you had an issue with the pituitary, you might find TRH levels would be very high. So, but typically, routine monitoring, we're doing T3 levels, we're doing TSH levels as far as hypothyroidism goes. Anyway, so again, just note you can have a primary problem, have a secondary problem, and then a tertiary problem with more of the hypothalamic hormone there. So as you might imagine, with hyposecretion, we can just replace the hormone. We can give thyroid hormone to replace what we're not producing ourselves. With hypersecretion, we're going to have to do either an issue where we actually potentially take out the gland itself, right? So there's cases where we can radioablate it potentially, so we can use radiation to get rid of it, or we can resect it in cases like cancer and things like that. Or we can actually give drugs to prevent production of the more active T3, as we'll see. Now, which metal is really important for production of thyroid hormone? Iodine, right? So we're going to need iodine. Now, remember, iodine is going to act kind of like a double-edged sword in a little bit. You see that you need to make sure you have enough iodine, but not too much iodine, because otherwise you can run into problems. So anyway, just another picture kind of showing the hypothalamus down to the anterior pituitary onto the thyroid gland. Remember that negative feedback loop, right? So T3, T4 is going to cause a negative feedback inhibition of this levels here. However, if we didn't have enough T3 and T4 being made, TSH levels you'd expect to be higher than normal, right? So again, that would be more of a primary issue there. So looking at the thyroid replacement agents, we have a couple of different varieties, and we'll go into specifically how this gets made in a little bit. But the main one you think of when you think someone with hypothyroidism, you think of what drug? Levothyroxine, or? Yeah, I think Synthroid, right? So, and actually, if you look at it, levothyroxine is T4. So actually, we're giving the inactive form, and we're going to have it be converted in the body over to T3. There's some other varieties, but Synthroid is by far and away the most common one we're going to use here. And so this is usually going to be the treatment of choice here. The thing you have to think about with the thyroid gland is how long do you have to wait before you really start to check levels again and wait for things to happen? Is it a quick process? No, everything with the thyroid is slow, right? So again, think like 4 to 8 weeks before you're starting to check levels again. So the nice thing about Synthroid, it has good consistency in its effects, good consistent potency. You're going to find it has a good long duration of action, and we have actually some parenteral forms that are available. We don't use it too frequently. Most patients are going to use this orally. And in fact, the only places I've seen parenteral levothyroxine being used is with TransLife. Anyone know what that is? TransLife? This is basically going to be a patient who is declared brain dead. They actually have people who come in from TransLife who will keep them physiologically alive and stable long enough for organ harvesting, right? And so if you ever see that like up in the ICU, it's very cool to see. Obviously not cool for the patient who's now brain dead, but it's cool to see their processes and their regimens for drugs they're going to give, because as soon as a patient's brain dead, everything goes haywire, right, from a brain down standpoint. So we have to replace their thyroid hormone, we have to manage their blood pressure, we have to manage their glucose, and all these different things, because again, they're just really not having a lot of signals coming out to regulate a lot of these hormones. I digress. So big thing to note here is that lidothioneine is another product that's available. This is actually the T3. This is much more physiologically active and is going to be much more quick acting than you see with Synthroid. So again, most people are on Synthroid, but it takes time for it to really kick in. There's also, other varieties you can have available. So one called Liatrix, which is actually a 4-to-1 ratio of T4 to T3. This is more the natural sort of ratio you would find in the bloodstream at any given time. But again, you may think it's more natural, but it doesn't really work that much better than Synthroid would given on a long enough period of time there. But main places we're going to use this in case we have things like Hashimoto's thyroiditis. So again, we have an autoimmune destruction of the thyroid gland. We can replace that thyroid hormone we're not producing anymore. Mixed edema, which is kind of a more kind of chronic sort of hypothyroidism. If we've removed the thyroid, or if we kind of use radioiodine to ablate the thyroid itself. Anyone know what radioiodine ablation is? Sort of, yeah. So we give radioactive iodine, right? So again, it will, and iodine likes to accumulate in the thyroid gland, and so we'll actually get uptaken preferentially in the thyroid gland, and then it will sit there and emit, beta and gamma rays, which will denature all the DNA and the protein and stuff in the thyroid gland directly. So it's kind of a nice kind of local way to try to either shrink down the thyroid gland if you're getting ready to take it out with surgery, or to just kind of burn it out, and then you'll have really no function at that point. So, but we still need to replace that because everyone needs thyroid hormone, so we can replace that with usually Synthroid for the most part. So again, how this is going to be working, it works very similar to other hormones where it's going to get down to the nucleus. T4 has to be converted to T3 to have full activity here. So once it gets into the nucleus, it can change gene transcription, protein production, all kind of good stuff, just like a glucocorticoid would or just like testosterone would. So we have a couple of antithyroid drugs here, and so we have drugs that actually help to prevent the production of T3, so usually help to inhibit that conversion of T4 to T3. And so we have a couple ones here called propylthiouracil, which is called PTU, if you ever hear that, and then another one called methimazole. Again, for the most part, these don't get used too frequently, but occasionally you have a patient with hyperthyroidism that needs it. For the most part, pretty well tolerated. Very rarely you can have agranulocytosis, but again, not enough people actually use this for you to see this with any kind of regularity. But again, you would want to monitor CBC for those patients. Let's see. So again, basically how these are going to be working, they actually inhibit this oxidation step of iodide, and so they actually prevent iodine from being utilized to produce T4 and T3, and then kind of peripherally they'll also help to prevent the conversion of T4 over to T3. So by inhibiting that, you have less activity of the thyroid gland, so it can help to reduce some of those symptoms. So maybe get their sweating under control, and get their blood pressure and heart rate down, things like that. So again, usually you're going to use it for things like Graves' disease, goiter, things like that. These can help to kind of shrink the gland down prior to surgery as well. Okay, so just looking at the normal process here for how you normally produce thyroid hormone. So again, iodine is going to be important to come into these follicular cells here. And so again, this is the thyroid gland itself, and basically you're going to find this organification process where tyrosine gets involved here, and you're going to form either one of two products. You're going to have monoiodotyrosine, or you're going to have diiodotyrosine. The only reason why that's important is because if you put two diiodotyrosines together, what do you think you get? T4, right? I put a mono and a di together, I get T3, right? So again, you can produce some T3 on your own. There's actually a kind of an inactive form called reverse T3 that gets produced. Again, that's not going to be physiologically active. But again, T4 can get carried out and then can be further converted peripherally and over into T3, which is, again, the more active form. So just know that by giving too much iodine, you can stop the production. That actually will inhibit the whole process. By not giving enough iodine, you cannot have enough precursor to actually produce thyroid hormones. So it's kind of a double-edged sword there. Here's an example of that radioactive iodine I mentioned being given. And actually what's kind of interesting is if there was ever, given today's international tensions with certain countries, maybe nuclear fallout is something you have to consider, right? So for instance, if there was ever a nuclear blast and you survive that, the follow-up effects are going to be, potentially devastating. And actually, one of the issues you have to run into is having this hypothyroidism that occurs, because one of the isotopes that gets produced in the nuclear explosion is this radioactive iodine. And so if you're not taking extra iodine yourself is normal, you'll end up uptaking that and it can actually ablate your thyroid. So I remember I had this really kind of crazy kind of survivalist professor who talked about this a lot when I was in school. So that's why I only mentioned it to you guys, just so I can continue on these needless tangents. But anyway, it is high incidence of delayed hypothyroidism. So that's why it's important if you ever survive a nuclear blast, you're ever in a post-apocalyptic sort of situation, make sure you take your iodine tablets. Or get something like povidone iodine, just kind of rub it on yourself to get some absorption with that as well. Okay, so again, there's a few different varieties of iodine we can give. Certainly, where does most of our iodine come from? Usually food, right? And our food's kind of fortified to contain iodine, but a lot of developing countries, they may not have enough of this available in their food sources and whatnot, so they may need some extra supplementation. But usually we either have something called SSKI, which is saturated solution of potassium iodide, right? Because again, potassium is what letter? on the, yeah, K and then I. So SSKI, if you ever see that, that's what that's referring to. And one called Lugol Solutions, kind of a similar product there. And usually this is used to treat hyperthyroidism. So we may give this in addition to things like PTU or methimazole to give just a ton of iodine to try to shut down production of thyroid hormone. So again, it could be useful for thyrotoxicosis or like a thyroid storm potentially. Let's see. So again, I'm not going to talk too much about this kind of thyroid trapping and all, or iodine trapping and all that, but this is basically the process how iodine gets converted into the active form. So basically converted over to iodine. It will then get organified to tyrosine. That's kind of where we're getting our T4 and T3 from. But anyway, so normally our kind of ratio here is T4 to T3. So just know that normally when you're measuring levels, you're measuring that T3, but that's the active form. That's usually the form that's less present in the blood, but that's the one we're actually concerned about because that's what's causing the main effects on our cells. Let's see that again. So we went over that already, so I'm not going to kind of belabor these points here. Just know that there's other drugs we can use potentially to prevent that process of converting T4 to T3. So if you ever have a patient with thyroid storm, if they ever get propranolol, you guys remember propranolol? What type of drug is that? Beta blocker, right? So again, if you think someone having thyrotoxicosis, you think they're tachycardic, hypertensive, beta blocker can help with that, but it also helps prevent conversion T4 to T3. So if you ever see that, it's kind of a unique kind of property of that drug. Other than that, I think I'm not going to talk too much about this, but there's an example of looking at this monoiodotyrosine, or I'm sorry, this is the T4 right here, thyroxine. I noticed the 4 iodines here. When it gets converted, it can get turned into T3, which only has, this is the active form, but there's also this reverse T3, it's actually inactive. So, but when we're giving, like Synthroid, again, not all of it's going to become, totally active. Some of it is going to get turned into that reverse T3, but this is the main thing we're concerned with here. Okay. Here's another case of and again, iodine is also found in a lot of contrast media, and so when you're going for imaging, either like a CT scan or something like that, iodine's used in a lot of those products there. And this is another one where we can actually use it for thyroid storm to help kind of prevent that conversion of T4 to T3. But yeah, other than that, that is the majority of it. So again, hypothyroidism, think Synthroid, think levothyroxine being the main thing to replace it. Thinking about inhibiting thyroid production, think about iodine, think about methimazole, PTU. Those are the main things we're going to be using there. Okay, so that's it. That's the end of the material for the next test. So kind of a wide smattering of things. Do you guys have any questions I can answer prior to next week?
The SSKI, so it's for hyperthyroidism.
Typically.
What does it do specifically to the hormone?
So again, by giving a ton of potassium, a ton of potassium iodide, that actually shuts down that process. It's kind of like activating almost like a negative feedback loop. So again, you want just the right amount. You kind of want the Goldilocks amount of potassium iodide. You don't want too much, you don't want too little, just right. Any other questions about any other stuff we cover? Room?
Sorry,
yeah.
this is about this.
Yeah, that's fine.
So, the drugs you don't have mechanisms of action on, those are basically stopping the conversion from T4 to T3.
Yeah, or preventing just production of thyroid hormone in general, yeah. Yes, sir.
Isn't the ablation for hyperthyroidism?
Typically, yes. Yeah, if they have like cancer or something like that, and you're they're in a hyperthyroid state, yeah, that's when you'd want to do the ablation. Because you get goiter either from having underproduction of thyroid hormone or from overproduction, right? So if it's too active, so you see hyperplasia of the tissue. But in other cases where, say, like you're iodine deficient, you have a lot of TSH just stimulating that tissue to grow, but it actually can't produce any thyroid hormone on its own. So you can see goiter in lots of different cases. Any other questions? I'm sure you guys will think of stuff, so email me. I will grade the quizzes as soon as I can. Don't forget your prescription assignments are going to be due next week as well at the time of the test. Anything else I think of? All right, well, I'll see you guys next week then.